A very good evening to all of you and to the esteemed panel that we have today with us, and also to all the audiences who have logged in for this program. So, on behalf of MedManor, we would like to thank you for spending your valuable time with us. And as we go ahead and start the presentation with the Dr. Sheetal, before that, I would like to give a small glimpse about the MedManor Organics. MedManor Organics is a high quality healthcare innovating for excellence company. We are based out of Hyderabad. We have originated in November 1998, starting from South India and gradually spread into the pan India. Our vision is to become one of the most admired pharmaceutical company in India. We have emerged as a strong player in dermatology, gynecology, neuropsychiatry, cardiodiabetic, respiratory, pediatrics, and we have about 1500 field force with about 9 divisions, which is across the country we are catering to. Also, we have at the moment the company size is about 220 crores company, so about 1500 field force and 9 divisions, and also present international markets. MedManor forays also into the R&D technical collaboration with US for the biosimilars. So this is our R&D facility, which is based in Shamirpet in Hyderabad. And we have come out with way ahead in biosimilar research, innovative biosimilars in pipeline for psoriasis treatment, like adalimumab, etanercept, infliximab, some to name a few. We have an indigenous manufacturing facility for all dosage forms, which is ultra modern, indigenous, and also WHO GMP certified. MedManor believes in scientific drive and promotion. So that is the reason where a world-class journal like Dermatology is associated with us. And we are the only company which has been giving this dermatology journal to all the dermatologists in the country. Apart from it, Cutis, skin sites, mycology updates are some of the few, in fact, scientific drives are over here. We do a lot of more scientific drives, and scientific driven promotion is the base of the marketing for this company. Keto, our most prized brand, is awarded as the brand of the year in subchronic category by AWACS in 2016. And it is one of the fastest growing company in top 20 derma companies. Moving forward, today we are here with the topic of the meeting, that is antifungal itraconazole, and it is my esteemed gratitude and it is my esteemed I am really obliged that today I am going to present this esteemed faculty which is present over here, which comprises of Dr. DG Saple from Bombay, who is our moderator, Dr. Sheetal Pujari from Bombay, who is a speaker, and then a panelist of comprising of Dr. Milind Deshmukh from Nashik, Dr. Anupama Kurjarkar from Goa, Dr. Nitin Chaudhary from Pune, and Dr. Sushil Pandey from Nagpur. So this is the esteemed faculty that is going to present us today on this topic of antifungal itraconazole. But before going ahead and handing over to Dr. Saple, I would take this chance on behalf of MedManor and behalf of everybody to introduce, though Dr. Saple doesn't need an introduction, but a brief introduction from my side about Professor Dr. D.G. Saple, who is the honorary professor and head dermatology, venerology, and leprology, Grant Medical College, and Sir J.J. Group of Hospitals, Mumbai. Doctor is a pioneer research and clinician in HIV/AIDS in India, first dermatologist in India to use fluconazole 150 mg daily dosing, consultant in dermatovenerology, leprology, and HIV and AIDS. Doctor is practicing in Breach Candy Hospital and SL Raheja Hospital and Fortis Associate, Mumbai. Trainer for fellowship program in HIV/AIDS, IADVL, ex-president of IADVL Maharashtra branch, ex-president of College of Physicians and Surgeons, Mumbai, examiner for MD, various universities, delivered 1,000+ lectures across the country and represented the country at over 108 international events. ex-editorial board member of IADVR textbook of Dermatology, USTD and UD, 40 plus peer-reviewed publications, chapters in medical textbooks, 55 plus papers presented in international conferences, conferences organized like national conferences, STD and AIDS, HIV, AIDS therapy in various 5 years of 2007, 2009, 11, 13 and 15, international collaboration in academic research with Harvard School of Public Health, John Hopkins University, University of Yale, University of Toyama and Osaka, University of KwaZulu-Natal, University of Roma, amongst many others. Lifetime achievement conferred by Indian Medical Association in 2017, Bombay, and also Lifetime Achievement Award conferred by the Indian Association of Dermatologists, Venerologists, Leprologists in 2018, Maharashtra. Best Practitioner Award at Dermacon International Congress 2019, honored as a mentor for IADVL Fellowship Derma 2020, current research project on dermatophytosis clinical research. These are some of the very few accolades of Dr. D.G. Saple. I wish and I request Dr. Saple to please take it over from here, sir. Sir, please.
Yeah, thank you, Shubhajit, and thank you for giving me this opportunity to moderate session on dermatophytosis and itraconazole. It's very good that you mentioned and you are given the features of your company. So we are happy that your company is interested in the quality product, which we want it, and you very much is interested in the research. So talking about today, we have got speaker, Dr. Sheetal Pujari from Mumbai, and we have panelists. So can you project the slide of Dr. Sheetal Pujari?
Yes, so I will do.
Of course, Dr. Sheetal is professor and head of the department of KG Medical College at Sion, that is Mumbai. She was president of IADVL Maharashtra. She is well known working at the national level. She had about 48 publications in the national international journals. She is a chairman's awardee for research in Somai Educational Achievement Awards and founding member of Bioethics Units of UNESCO, chair of Bioethics. So we'll have talk about itraconazole in dermatophytosis from Sheetal, and we'll have panelists. Can I have next slide, please? Yeah. Subhajit, next. Yeah. Dr. Milind Deshmukh from Nashik. His work as a university teacher and postgraduate at UG PG in dermatology, MUHS. He is the director of Aditya Laser Center, Nashik, practicing as a dermatologist for the last 30 years. And his area of interest is the pediatric dermatology and dermatosurgery. Next slide, please. Yeah. Next panelist. Yeah. We have Dr. Anupama Kutcherkar from Goa. Anupama, she has got 2 publications. She is practicing in Goa. She was the president of IADVL in 2002 and 2022. She published 4 books, and she writes column in newspaper and magazine. And she is a consultant at Healthway Hospital, Goa. So we'll have Anupama as next panelist. Yeah, next one. Nitin Chaudhary. Dr. Nitin Chaudhary is from Pune. Is a professor and head department of dermatology, venerology and leprosy, Srimati Kashibai Naule Medical College and General Hospital, Pune. He had 22 publications. He is a MD examiner for various universities. And Dr. Nitin Chaudhary is practicing for quite long. He's also one of the senior dermatologists. Yeah, next one. And now we'll have last panelist, Dr. Sunil Pandey. Sunil Pandey, he's finished his graduation, post-graduation from Mumbai, that is GS Medical College. He's the editor of Indian Journal of Drugs in Dermatology, Associate Professor of Dermatology, NKP Salve Institute of Medical Science, Nagpur. Is the ex-research officer of GSMC and KMH Mumbai, co-editor IJDVL. and he has got many more awards, and a fellow of dermatopathology, Hamburg, Germany. So we have got very good panelists which represent real Maharashtra, that is from Nagpur, Pune, and of course Maharashtra and Goa and Nasik. So this is a good presentation for all over Maharashtra. So now I'll request our speaker, Dr. Sheetal Pujari, to go ahead with her talk.
Okay, so my topic is on itraconazole today in this session on dermatophytosis. So I'll be speaking briefly on itraconazole and subsequently on the new product that is Suba itraconazole, which is the in thing nowadays. So a brief introduction to our dermatophytosis, we already know this, but just to set the ball rolling. It has become a pandemic with no end in sight. Hopefully we are looking at the end of the COVID pandemic, but this pandemic of dermatophytosis does not seem to be ending. We all know about the non-responsiveness and partial response to treatment, repeated recurrences, increase in occurrence of familial tinea. And it is not only India which is suffering, but more and more cases are being reported in our neighboring SAARC countries, as well as several reports coming in from Western countries, European countries, as well as from Japan. So these are the definitions. Some of you must have already read it from our ITAT consensus guidelines. Chronic dermatophytosis is defined as the presence of glabrous tinea for a duration of 6 months or longer, continuous or recurrent, with or without treatment. Recurrent dermatophytosis is reoccurrence after 4 weeks of stopping treatment following clinical cure. Resistance dermatophytosis is a failure to eliminate dermatophytosis despite administration of one or more antifungals for an adequate dose and duration, and it is associated with proven mycological resistance. Recalcitrant dermatophytosis is a more global term which includes persistent glabrous tinea in settings like chronic, recurrent, corticosteroid modified, and resistant cases with poor or no response to standard treatment. So this is from the IDWL ITAT consensus guidelines. As far as the organism is concerned, most of us who have done studies have realized that Trichophyton mentogrophytes is increasing in proportion as compared to Trichophyton rubrum, which was majorly up to 80 to 90% in earlier studies. Trichophyton in most of the studies has been proven to be mentogrophytes in most of the studies which we are doing now, but it has not really surpassed rubrum, but it is definitely about 40 to 50% as compared to 10 to 20% before. Even the nomenclature has been in question, with some authors naming it as Trichophyton mentogrophytes type 7, some naming it as Trichophyton interdigital, and the most recent reports suggest it as Trichophyton indothenium with a distinct set of clinical and mycological features and genomic features. As far as practical aspects are concerned, when we do a culture, it is a granular variant with rapid growth on culture. Previously, where the culture used to take about 3 weeks to grow, this grows in about a week, and definitely there are rising MICs, especially to terbinafine, to some extent to even grisofulvin, and very few cases to fluconazole. It is a proven fact that many of these organisms have been shown to have squalene epoxidase mutations. As far as itraconazole is concerned, thankfully, there have been no report of rise in MICs in most of the studies, although there are scattered reports where there have been multi-drug resistance. So itraconazole is the go-to drug as of now. So this was from our study, which we did way back in 2015-16, where distinctly you can see, this is a snapshot of the table actually from the published study. This was an IDWL funded project. So terbinafine, you can see that the MIC levels have definitely increased, whereas the others are not showing much increase, except for grisofulvin a little on the higher side, but not much. So basically, what is our antifungal arsenal now? Grisofulvin we are using, very good for tinea hepatitis, but for other forms of tinea, not much useful. Terbinafine, even with increased dosage, there has been no response reported from majority of parts of India, but some people do report good response, especially in naive cases. Fluconazole has shown good response in most cases of pediatric tinea. There are some reports like Sir has performed a study where daily fluconazole is found to be useful. Itraconazole is still effective in most cases, but response has been variable in some of the cases. But by and large, our prescriptions have majorly shifted to itraconazole in dermatophytosis with no other drug in sight. A brief overview of the pharmacology of azoles. As we all know, there are imidazole derivatives, the older ones, ketoconazole, the topical ones like miconazole, iconazole, and clobramazole. And the triazole derivatives are itraconazole and fluconazole. And they act by inhibiting the sterol 14 alpha demethylase. And they are mostly fungistatic, although the ultimate effect may be fungicidal depending on the drug concentration and the organism. But by and large, it is supposed to be fungistatic. As far as the dosage is concerned, previously when we were residents, 100 milligram OD was supposed to be sufficient, but most of us are giving 100 milligram BID dosage in dermatophytosis. Duration was a standard 2 weeks for tinea corporis before, but in current scenario, we definitely give for 4 to 6 weeks for tinea corporis. For tinea pedis, we will go up to 8 weeks. Pulse dosage can still be given in onychomycosis. Which was the standard therapy before as well. Thankfully, onychomycosis has not been a major problem in the present pandemic. So one thing less to worry about in this pandemic. As far as the other side effects are concerned, we know that azoles, especially itraconazole, has got lot of drug interactions with drugs such as cyclosporine, phenytoin. So anti-epileptics, we have to be very, very careful. Concomitant use of atorvastatin and itraconazole is definitely to be avoided because of the risk of myopathy. Warfarin is another drug where we have to be careful with. If you are giving with itraconazole, better to be avoided. As far as the antifungal spectrum of itraconazole is concerned, it has a huge wide spectrum. That is why it has been widely used even in HIV infection with opportunistic infections. So it is effective against histoplasma, coccidioides, blastomycosis, cryptococcosis, candida, sporotrichosis. Dermatophytes, all three species, all three genera are effectively controlled by itraconazole. It is effective against Malassezia furfur as well. Resistance can occur, but it is relatively rare. But if it occurs, there is generally cross-resistance between azoles. A brief word about itraconazole in candidiasis, although it's not the topic for today. In candidiasis, fluconazole remains a drug of choice, but slightly there is definitely an increase in non-albicans species, even in cases of candidal vaginitis, and increasing instances of resistance to fluconazole, where itraconazole may have to be given. As far as the formulations of itraconazole are concerned, they are available mainly as capsules and as oral solution. Oral solution is supposed to be 30% more bioavailable than capsules, but it has not been very popular in India at least. And we all know that itraconazole has to be taken with after a full meal or an acidic beverage to improve the absorption. If the patient is on proton pump inhibitors, generally they are to be stopped because it will reduce the absorption of itraconazole. Oral solution is supposed to be taken preferably on an empty stomach. And the steady state levels are generally reached after 1 to 2 weeks of therapy. Itraconazole, we all know that there are challenges of bioavailability. First of all, there are quality issues which definitely impair the bioavailability. In the formulation, it is a pelletization, which is very, very important, that I believe will be discussed in the panel discussion as well. An acidic environment, as I mentioned before, is a very important requirement for absorption of itraconazole, as itraconazole is a weakly basic BCS class 2 drug with a pH dependent dissolution. So it requires an acidic gastric environment, and antacids would increase the absorption. And a heavy fatty meal increases the absorption. The dissolution would be limited to the gastric environment, and this results in a supersaturated solution of the drug in the stomach. And therefore, there is wide interpatient variability in bioavailability and also poor gastrointestinal tolerability of this conventional pelletized itraconazole formulations. So what is an ideal formulation as far as the pelletized capsule is concerned? It has to be a small bead size, ideally 30 by 40 mesh size as it is called. An optimal drug to polymer ratio 1:4. Sugar beads should be there, and the optimal number of pellets is what is important, supposed to be more than 500. And the HPMC as a film forming polymer and a thin coating layer would result in a faster dissolution rate and higher bioavailability. However, even with the best formulations, it is said that we can only achieve 55% bioavailability. So that is where actually suba-itraconazole comes in. And one thing is about the pellet issues, quality issues. There has been a study by Sardana et al., which they actually did the morphometric assessment of various itraconazole brands, and they found wide variability in the pellet formulation. As you can see in the marked area, there was wide difference between the number of pellets. It varied between 121 to 820. And even the average size of the pellets varied from 959 to 1845 micrometers. So you can imagine the variability across brands. So pelletization, because of that formulation problem itself, becomes an issue. So suba-itraconazole overcomes these pellet issues. It is basically a solid dispersion of itraconazole in a uniform non-pellet formulation containing a specific pH-dependent polymetric matrix, which is hydroxypropyl methyl cellulose phthalate, HPNCP as it is called. A suba-itraconazole is released and absorbed in the small intestine as against the gastric, which occurs in the conventional itraconazole. So it is the main site of absorption of itraconazole. Suba-itraconazole becomes the small intestine, and there is increased bioavailability, and there is less individual and inter-individual variability as far as the absorption of suba-itraconazole is concerned, or the supra-bioavailable as it is called. It has been approved by US FDA for blastomycosis, both pulmonary and extrapulmonary, histoplasmosis, including chronic cavitary pulmonary disease and disseminated histoplasmosis, and aspergillosis, especially in patients of pulmonary and extrapulmonary aspergillosis who are either intolerant or refractory to amphotericin B. So basically, it is not US FDA approved for dermatophytosis, but nevertheless, it can be used definitely. So the advantages of suba-itraconazole is more consistent bioavailability. Absorption is less affected by the gastric acid suppressive agents, and there is comparable absorption under both fed and fasted conditions. So as you can see from one of the tables taken from one of the publications, that it reaches almost similar levels in both fasted and fed conditions. Therefore, it can be taken with or without food. So that is a major advantage as far as the compliance of the patient is concerned. Not only that, there are some studies which have shown that there is a slightly higher bioavailability in a fasted state and with administration with omeprazole. So this is useful in those patients who are unable to have a high fat content, means sick patients, like who are those on chemotherapy or after surgery. So you can give even in those patients. So it is useful in critically ill patients who would require even the proton pump inhibitor prophylaxis. So this is a tabular differentiation between suba-itraconazole and the conventional itraconazole. As I mentioned before, suba-itraconazole is a non-pellet formulation. Whereas a conventional one, as we all know, is a pellet formulation. The polymetric matrix is different. It is HPMCP in the suba-itraconazole, whereas it is hydroxypropyl methyl cellulose in conventional one. The site of absorption of suba-itraconazole is small intestine, whereas it is stomach in the conventional itraconazole. The bioavailability is much more as compared to conventional itraconazole. In some of the studies, it has improved by at least 173% vis-a-vis conventional itraconazole. As far as interaction with food is concerned, suba-itraconazole can be mentioned in fasting, can be administered in fasting state, whereas conventional itraconazole has to be administered after a full meal for adequate absorption. As far as effect of antacids is concerned, the suba-itraconazole in some studies have shown in fact an increase, a 22% increase in total plasma levels after co-administration of omeprazole, whereas with conventional itraconazole, with omeprazole, it reduces the Cmax by 66%. The inter-subject variability is very low in suba-itraconazole in the patient as far as daily inter-patient variability is concerned and between the patients. And what are the doses which are available? It is a 50, 58, 65 in suba-itraconazole, and now 130 milligram is also available. And in conventional itraconazole, as we know, is available as 100 milligram. Although 200 milligram is available, but that is not the dose which is to be used, because whatever 200 milligram is available is actually not a proper pellet formulation. So basically, the 50 milligram and the 65 milligram is supposed to be equivalent to 100 milligram of conventional itraconazole. As far as what is the difference between 60, 65 and 130 is concerned, we'll discuss in the panel discussion. So this is basically a diagrammatic representation as to what happens with itraconazole. It gets released at acidic pH of the stomach. So it gets ionized and precipitated in the stomach. So there is less drug available for absorption, and this leads to poor bioavailability. So what happens with suba-itraconazole? Now, since the HPMCP polymer is resistant to acidic pH and gastric secretions of the stomach, it remains as it is in the stomach. It bypasses and enters the duodenum, and it is in the small intestine where it is absorbed. So it is basically, this particular polymer is designed to dissolve at the duodenal pH of 5 to 5.5 for maximum absorption. So there is increased absorption, increased bioavailability, and definitely because of that, greater clinical efficacy. So these are some of the studies. Actually, this was an open label crossover oral bioequivalence study, which compared a 3-day loading dose regimen and a 15-day steady administration of suba-itraconazole and conventional itraconazole. So you can concentrate on the rectangle which I have marked out. So if you compare the ratios of conventional itraconazole and the suba-itraconazole, so it was between 107% and 118% in both the studies. So basically, it was between the bioequivalence range of 80 to 125%, which is recommended by US FDA. So in this study, if you see, it was 65 milligram which was used. Now, effects of food and omeprazole, like I mentioned before. So what happens to the effect of food and omeprazole? So you can concentrate on the rectangular part which I have marked out. So basically, suba-itraconazole demonstrated similar concentrations at the end of dosing interval with modest lower total and peak itraconazole exposure being shown when it was administered under fed conditions than when it was administered under the fasted state. So basically, it can be given in the fasted state and even with omeprazole, and in fact, a slightly more Cmax is observed in these conditions. This is another pharmacokinetic modeling which they have done of itraconazole and hydroxyitraconazole for oral suba-itraconazole. So what they have said was the relative bioavailability of suba-itraconazole compared with that of the innovator brand. As you can see, it is mentioned Sporanox. It was 173%, and 21% less variability, interpatient variability was observed. Food resulted in a 27% reduction in bioavailability and 58% reduction in the transit absorption rate compared with that of the fasted state. Now, this was a study from India, a real-time study actually. This was an open-label randomized double-arm clinical trial to compare the effectiveness of supra-bioavailable itraconazole and conventional itraconazole capsules. Here, I believe the 50 milligram was used. Here again, it was found to be equivalent to the conventional itraconazole. 50 was found to be equivalent to conventional itraconazole 100 milligrams. So basically, they said that there was more rapid improvement and higher complete cure rate than with conventional itraconazole. In the suba-itraconazole group, 65% patients achieved a complete cure, whereas the same was achieved by only 33%. So it was definitely more superior. There is also an unpublished Indian study where they found that the sebum concentration of suba-itraconazole and conventional itraconazole was compared, and suba-itraconazole was found to achieve a sebum concentration of 11.6% higher. So higher drug concentration is achieved at the target site basically. So it might be responsible for the better improvement as compared to the conventional itraconazole. A word of caution though, with increased absorption. So why I mentioned this was because we are now having 130 milligram also. So with increased absorption, we have to be aware, we of course are aware, all of us are aware that cardiac side effects occur. But with this increased absorption, we have to be a little careful for signs of cardiac failure in vulnerable patients. So as of now, no study participants, of course, have been observed to demonstrate any signs of electrolyte imbalance, hypertension, or heart failure, but this is just a word of caution. So these are the formulations which are available, as I mentioned in the table also, 50, 58, 65, and 130. In India, the 50, 65, and 130 are available. The 50, 58, and 65 are equivalent to 100 milligram of itraconazole, whereas 130 milligram is equivalent to 200 milligram of conventional itraconazole. As far as whether to use 50 milligram versus 65 milligram, in my personal experience, I feel 50 milligram is equivalent to 100 milligram. But if you feel that the patient requires a higher dose, you may go for 65 milligram. But by and large, 50 milligram is sufficient. So concluding, suba-itraconazole has better bioavailability, achieves steady state levels, Intake in fasting state is possible, with anti-acidity drugs is possible. So definitely there is a better compliance of the patient, and it's a valuable addition to our antifungal arsenal in the present pandemic. Thank you for a patient hearing. I'll stop share and over to the panel discussion.
Thank you, Sheetal. It was very educative, and you have completed, I think, whatever clinicians in a need of information about suba-itraconazole, because itraconazole, you are listening to it for a long time. You have made it very easy for the clinicians. And now we'll open for the panel discussion. But let me share my slide. I think all panelists, Sushil, are you there?
Yes, sir. Yes, sir. Yes.
Yeah. Okay. All of them are there. So we'll start. We are going to cover, of course, this is a subject which is troubling us, all practitioners, clinicians, because still we are finding very difficult to manage these cases. About the epidemiology, about 25% of the world populations are having the filamentous fungus, and the prevalence in our country is almost ranging from 30 to 78. And now it's considered as a pandemic. It has not remained only confined to the country. So the first question I'm asking, Anupama, are you there? Okay, I'll ask Dr. Nitin Chowdhury, what is the percentage of patient coming to a clinic is having fungal infection?
It is more than 30%.
Okay, yeah, most of the doctors are telling, and this is across the country, almost 25% there. So the next question I'm asking Dr. Sushil Pandey, what are the challenges we are facing in tinea?
I think, sir, there are many challenges in the management of tinea, although the diagnosis has become relatively easier and common to us. What I feel is that the tinea we are getting more patients of tinea incognito than patients who have applied, that means the patient who has applied a lot of corticosteroid. Second challenge is extensive dermatophytosis that we are getting instead of localized ones. And many family members are also getting affected. So these are the basic challenges as far as the agent and the host factors are concerned. And one of the important challenges that we are facing as far as the drug management is concerned is the recurrence and the chronicity of the disease because of the lack of fungicidal agents.
Thank you, Sushil, for covering most of the points. I entirely agree with this. Yeah, you want to mention some more?
Yeah, so in tinea incognito, the main problem is also that the steroid is strong anti-inflammatory agent. So it suppresses the characteristic clinical features of tinea. There is no characteristic border, there is no scaling. So most of the time, it is very difficult to diagnose also that it is a tinea or something else.
Yes.
And the patient keep on applying the steroid as if he has become addictive to that. And as soon as he stops it, it in fact increases, and he is very reluctant to stop that steroid application, because when he applies on that antifungal cream, it causes more of irritation, dryness, and other problems. So for the first few days in the management of tinea incognito, topical treatment should be, I think, restricted only to the moisturizers, and we should give more stress to the oral antifungal itraconazole. And then after a few weeks, then we should shift to oral as well as topical antifungal.
Anyway, so these are the many challenges. One of the difficult challenge you mentioned, that is tinea incognito, especially when they are using the steroids. Winning over is very difficult. That questions we are going to cover, but there are many.
Sir, can I add a word?
Yes.
So, considering the challenges which Dr. Chowdhury and Dr. Sushil has just mentioned, different clothing habits, taking the treatment to the end till the point of clinical cure is not done by many patients as well as many clinicians. So far as the symptoms are relieved, they think that the disorder is controlled and cured. So I think that is again a challenge for a consultant or a dermatologist to ensure that the treatment is taken till the end?
Yeah, thank you for that. So there are many challenges where, like drug-drug interaction, high doses, there are many challenges. Lack of counseling, side effects, there are many challenges. So next question, this is the patient, she was taking antifungal for 2 years. So I'm asking Anupama, can you consider is an acute infection or a chronic infection? Fungal, you like to consider now is an acute or chronic infection? Anupama, are you there? Otherwise, I'll ask Sheetal.
Yes, sir. Can you hear me?
Sheetal?
Sir, I think Anupama has to hold her mic closer. She is not muted actually.
Hello. Yeah, can you hear?
Anupama,
Yeah, now you can.
I'm
Yeah,
asking,
now we can.
what we are dealing with this dermatophytosis, do you think is an acute infection or chronic infection?
Since she is having it for very long period, sir, it
Yeah,
looks
2
like
years.
chronic. So it looks like chronic infection. Maybe she is relapsing again and again. Maybe she is taking inadequate treatment.
Yeah, you're absolutely right. So we went to literature and then found that Journal of American Acad. What we are dealing is a delayed type of hypersensitivity. So is a chronic infection. So nowadays we have to consider the chronic infection in most of the cases. Okay. So these are the additional information that from the literature. We have to consider the T cell is involved. That is a delayed type of hypersensitivity. Yeah, so next question is about because everybody used to talk about resistance. So Sheetal, what do you think about the resistance? Yeah.
Studies have shown definitely that squalene epoxidase mutations are there, but that might not be the only reason, because some of our patients are not responding well to itraconazole also. So there are definitely patient factors in addition which have contributed to the present pandemic. But definitely there is a basic resistance to terbinafine that is definitely there, because most of our patients are absolutely not responding to terbinafine. But other factors also which are well in our hand that we should tackle when we are dealing with this pandemic, sir. So those factors we should not forget, the patient factors and the environmental factors.
Thank you, Sheetal. I entirely agree. See, initially everybody was talking about resistance. I'm talking about 4 years before anybody's to come. Then we studied about it. Then we realized the resistance is very fractional, is not. And then we conducted poll across the country and we asked the simple question: any patient comes to your clinic and you start antifungal treatment, what is the percent of patient responding initially? So no, it was almost 75%. And then with the background of HIV, we realized what we are dealing is not dealing with the resistance. Most of the cases probably is a clinical failure. So Dr. Sushil, what are the causes of clinical failure in our clinical practice? Yeah.
Sir, I actually entirely agree with Sheetal ma'am and as well as to you that majority of our patients, they do respond to azole group of antifungals. And if you consider terbinafine as a first line therapy, majority of them do fail. So there is a definite terbinafine resistance with regard to squalene epoxidase mutations. But majority of our patients still responds to azoles or itraconazoles or fluconazole for that matter. So therefore, I would label it as not as a itraconazole resistance, but as you rightly said, we require a little bit of a longer therapy and better compliance to tackle with this chronic dermatophytosis.
So most of the things we are dealing with this are the clinical failure more than the resistance cases or in clinical practice. So there are various causes, the patient factors, drug factors, as you mentioned, and clinician lack of counseling. And that's what. So the most common cause of failure is the inadequate therapy and lack of proper counseling. That's how and being a chronic infection, for any chronic infection, the dictum or the main important thing is a compliance, adherence, and that we can achieve by the counseling. So what he did, this is one of my study which has been published in IJDD, that oral itraconazole and topical ibuprofen. We started in 100 patient, 100 milligram BID for 6 weeks, and some patient for 3 months with the local ibuprofen application. Almost 30% of the patient, they have taken multiple systemic antifungal. And what we found, 82% of the patients showed complete remission followed for 1 year. 18% showed partial response to treatment. Out of 18, 16% then did not have good adherence and the compliance. 2% of them were on immunosuppressive drugs like prednisolone and methotrexate. And this 16% with the repeated counseling, there were a lot of patients, they improved, and none of the patients showed there was no clinical response. So there was no question of suspecting resistance. Then we say that itraconazole is working with the good counseling and the adherence. We tried terbinafine, but terbinafine we gave 250 milligram BID, we found result. Fluconazole 150, we found results. Of course, grizophulin we could not compare, but this is one of the study where we are shown that result is almost 80% followed for 1 year. There was no recurrence, and these are the patients. So the message here, this was done about 4 years back. The counseling, we could achieve this because of the counseling. Nothing, we have not changed. Even we could get the result to terbinafine also and fluconazole also. So failure of therapy, then we look for the international poor adherence to treatment. That was a cause. So again, I'm repeating, there are many causes, but interruption therapy and lack of counseling and adherence. Okay.
Sir,
I think yes, sir. Just
so anybody wants to add? Yeah.
Yes, sir. Sir, also family history is very important, because when one patient comes, many other family members are also having tinea.
Yes, correct. You are right. Yeah.
So
I'm going to cover that. That question is there, Anupama. Okay.
Yes.
I think, sir, just
Yeah.
I want to add one more thing. It's that you must realize that now it is a chronic dermatophytosis and it requires a long-term therapy. And you can't just rely on the antifungal drugs to take care of these dermatophytic infections. And that is where the role of compliance, counseling, and adherence comes into picture.
Also,
I think you
hygiene.
understand it better, yeah.
Yeah, Sushil, that's why about 3.5 years before that everybody is to come, I was very busy in HIV. I said, now time has come, I must shift to some other, and started taking interest in dermatophytosis. And the first thing what I did is I found, what is it? It's a chronic disease. And as you said, any chronic disease, the compliance, adherence, and that we can get it for counseling. So we could get result that because of only counseling, because this compliance can be achieved only by counseling. This is how that's why I thought of sharing this, my published study. Anybody else wants to add in that?
Absolutely agree, sir. Compliance and adherence to treatment protocol. Unless we do that, there is no end to this dermatophytosis.
Okay. So we'll go for the next question. Dr. Chaudhary, what should be the duration of the therapy?
The duration of the therapy should be minimum 4 to 6 weeks, and the treatment should be continued at least 2 weeks after the disappearance of the lesion.
After the clinical resolution. I agree. If you go by the book or what has given in the past, that's not enough. Nowadays, 6 to 8 weeks is the guideline. Even I think most of the people have accepted that. In few patients, you have to use for 3 months. Those are on immunosuppressive drugs, or they are suffering from immunosuppressive diseases. Very rarely we have to give for 6 months. So duration is now very clear according to this Indian guideline. Also, it has to be longer period, because it's a chronic. The treatment duration is very important, because if you do because longer duration, poor patient compliance, increased chance of relapse and recurrence. So duration is very important. So we'll go for next question. Next question is to Seetal. What is the role of updosing?
Itraconazole maximum we can updose to 100 milligram BD, not beyond that. Terbinafine, as already has been mentioned by other panelists, 250 milligram BD, that is 500 milligram per day. Even Grisophulvin, to some extent, we have updosed and seen maximum of 1000 milligrams.
Entirely agree with Sheetal, because many times we have seen they're writing itraconazole 400 milligram, 200 milligram BD, but it's absolutely assured that one of my study, we have used 100 milligram BID, and according to also literature, 100 milligram BID is enough, no need of raising the dose, and there are hardly any study. So we'll go for the next question.
Sir, there is a rationale for that.
Yeah.
In terbinafine, there is fourfold increase in MIC. So updosing of the drug would be permitted in terbinafine. And terbinafine is fairly more safer drug as compared to azoles. So
That's
maybe
absolutely right.
yeah. So we should not be updosing azoles highly or twice or thrice as you rightly mentioned.
Correct, absolutely right. Because terbinafine already we are using 250 BID, but he may require the higher doses. Okay, so we'll go for the next question. Dr. Chaudhary, what is your opinion of the combination of treatment? See, this one of my friend is writing itraconazole, terbinafine, grisophulvin to one patient, and he has got a printing in the computer. All patient comes to me from him, have the same thing. And then I was surprised, this is one of the government hospital, itraconazole, terbinafine, they have got a stamp, writing so many medicine together. So what is your opinion about that? Combining
Absolutely
multiple
no.
systemic antifungal drugs.
No, absolute no. And it should not be combined.
Yeah, I entirely agree with
We
you.
can combine topical and systemic antifungal, but no two systemic antifungal should be given at a time.
Yeah, it's absolutely right. We have to use topical and systemic combination, but not too many, because still one of my neighbor, I don't want to say, he was the head of the department, but even today is writing 3 drugs. So what will happen to the pill burden? What will be the toxicity? What will be drug interaction, cost, and the compliance? Is going to work? No. So I do not know why people are writing, but then all panelists will agree there is no need of combining multiple drugs. Sheetal?
No, sir. I don't think.
No,
So
sir.
now, Anupama, this question, what you raised, now we are seeing multiple family members are affected at the same time.
Yes, sir.
Yeah, so now can you elaborate about this?
Here we have to counsel them very well. We have to talk to them about hygiene, daily bathing, the clothing. They should wash their clothes, iron their clothes, or dry them in the sun. About their beddings, bed sheets, towels. So all these factors have to be taken into considerations. All the family members have to be treated at the same time.
That's very good point. Yeah. And we have to prescribe the drug, which should be affordable, no? Because many
affordable to them.
Correct,
Yes,
correct,
yes.
correct. That's very good, very good. So we'll go for the next updosing. We have mentioned about this. Now, this is a question I think Dr. Chaudhary, you have already mentioned, but see how many preparation and many patients of ours already they apply steroid. And as you said, when they apply steroid, they get relief from their symptoms. They are very happy. I think about 15 days back, one patient came to me. He is applying steroid completely for last 2 years. I explained to him, I counseled him, but he said, "Doctor, I want relief. What you are saying, I do not agree." And he came after 2 days, again applying. So, Dr. Chaudhary, can you explain how do you manage this patient? At least I am finding very difficult to manage this patient.
At the most, we should apply only topical moisturizer for first few weeks, 2 weeks, along with good systemic antifungal like itraconazole in full dose, and with proper counseling. And symptomatic management can also be given like antihistaminic for first few weeks. and later on we should give combination of oral as well as topical antifungal, and that should be continued for long duration. And counseling should be done that this is for your good, that initial few trouble you have to face for 2 weeks, but even if you apply this topical steroid for lifetime, it is not going to cure you. It will going to cause all the side effects of steroids like atrophy, then telangiectasia, other infections, and many more problems. So first, counseling again part is more important here, along with drug therapy.
Yeah, but I think I want contribution or input from other panelists because I'm finding it very difficult.
So we can explain.
Yeah.
Hello.
Yeah. Yes, Sushil.
Yeah, I think Deshmukh sir wanted to say something.
Okay.
Yeah,
okay.
yeah, Milind. Yeah.
Sir, we can explain the side effects of these topical steroids. Like it can be very easily seen in this picture what the damage has been done, and these are irreparable at times, and they are very difficult to manage these side effects of a topical steroid or a mixed form of formulation.
Yeah, it's very difficult, but then it depends now your rapport with the patient, how much patient believe in you, but as you said, we have to see that we have to scare them or give the reality of the what steroid can create a problem for them, and slowly they understand. But the patient coming first time your clinic is very difficult to treat. So we'll go for the next question. Yeah. See, now there are many oral therapy, grisofulvin, terbinafine, itraconazole, fluconazole. So I think I'll ask Dr. Anupama, which antifungal do you use? Systemic, I'm talking about, not. Yeah.
So nowadays, the first choice is always itraconazole.
So you're using itraconazole in each and every patient? So
no, except when the patient is having some cardiac problem, hypertensive, diabetics. In those, I prefer to use terbinafine, sir. And in children, I prefer fluconazole.
Sheetal?
The same as what Anupama said. First choice, itraconazole, terbinafine in pregnant females in polypharmacy, and fluconazole in children, sir. Grisofulvin in tinea capitis. Very rarely, naive patients I've tried to use, but generally it is itraconazole which is the first choice.
Grisofulvin, tinea capitis. So there are merits and demerits of each and every drug. But today, this is the children, and where we can use terbinafine, fluconazole, grisofulvin. These are drug can be used. This is the after treatment.
But sir, what is your experience with regard to grisofulvin? Because I reckon it as a weak antifungal drug. So what is your opinion, sir, on this?
I think we have used grisofulvin for many years because there was no other drugs when we were practicing. Yeah. So, but today we have found is not that good drugs, and I'm talking across the country. Most of the whatever the information I got, it is effective in 35 to 40%, not more than that. But they prefer to use grisofulvin in tinea capitis.
Yes.
But now there are a lot of studies where you can use terbinafine, itraconazole, and fluconazole because the short period. But grisofulvin is not that. But some of the people say it is, but still overall the effect is 30 to 40%, not more than that. Now the next question, the patient comes with the immunocompromised patients like diabetic patients, HIV patients on immunosuppressive drugs. These are the pictures where it's very difficult to diagnose. If you see the clinical picture, so Dr. Milind, how you are going to diagnose this patient? See, if you see clinical, first patient of mine who is a diabetic, second patient is HIV, third is the patient is on methotrexate, and the fourth patient is on oncogenic drugs.
So the first and foremost is
the patient shows a typical presentation.
Yeah. The first and the foremost is go for the morphology of the fungal infection if you are suspecting fungus at all. do a KOH mount, and again, going by the basics, the sites involved can easily go in for a diagnosis of dermatophytosis.
Yeah, because like tinea incognito here also, as you said, because the site we can suspect, but it's very difficult to pinpoint. So these are the places where we require KOH preparation. Sometimes you do a culture on culture and sensitivity or PCR, but at least KOH. So my request to each and every dermatologist, keep on microscope. Microscope is not buy the old one, because for KOH we don't require the high power. I think 40 power is enough. So each and every day, because I am using microscope the day I started my practice in my both clinic, I have got a microscope which is very useful. And we'll go for the next question. Next patient.
Just
yeah.
want to add, just it's about the diagnosis. I am tempted to tell you that if it is a scaly, it's if it is a scaly dermatophytosis or suspected case of scaly dermatophytosis, our first choice should be KOH. But if the scales are not apparent, don't hesitate to go for a skin biopsy with special stents.
Yeah, I entirely agree. In 3 patients of mine, we have done a biopsy because those patients were suspecting atopic, you know. One of the patients was suspecting atopic, but when you did a biopsy, we found it was dermatophytosis. So we'll go for the next question. This is the patient. Dr. Chaudhary, this patient came initially, you can make out here, no KOH is required, but if you are suspecting always. So this patient had very extensive tinea. We started antifungal treatment. After 15 days, see, almost everything disappeared. But after 1 month, again the patient come with the reappearance of the recurrence. So Dr. Chaudhary, what do you think of this patient?
It can be reinfection that that continued treatment should have been continued for more weeks rather than stopping after 2 weeks.
No, but after 15 days, everything is cleared.
That is the problem. The patient.
But we continue for 1 month. But at the end of 1 month, he came like that.
I think that it is not the drug resistance. It may be because of the compliance it has reappeared.
Yeah, it's a very good. Very good. You know, I was conducting a trial, but during the COVID period, many people from Mumbai, they shifted to their village. And this lady shifted to the village. She did not take the treatment. And when she came, again we started fluconazole, 150 milligram. From the beginning, I'm conducting trial for fluconazole. See, everything disappeared. So I entirely, so you know, these are the simple reason of recurrence or relapse, which is, we always think of resistance. The first common cause, find out whether they're taking the treatment regular. That's why I showed this. So we'll go now for the next. Itraconazole is the most prescribed brand that all of us, we have to agree, because that is the most effective drug also. If you ask me, in my clinic, I'm using only fluconazole. Very few cases terbinafine, some cases itraconazole. So we'll go for the next question. I think I'll ask Sushil, what are because now we are dealing with everybody's talking about suba itraconazole. So what are the advantages and disadvantages?
I think, sir, the biggest advantage of suba itraconazole is that that there is no inter-individual variability in terms of its absorption, and second, it is independent of food. So these are the two important advantage I could see with suba itraconazole if we compare it with the conventional itraconazole. But actually speaking, there is no DCJ approval or FDA approval because of the paucity of the data. So we really require a data to know whether the suba itraconazole has been outlined by the pharmacologist in terms of its specific or increased bioavailability, whether it actually translates into clinical efficacy, that is something that needs to be known.
I agree with you, Dr. Sushil, that these are the data because these drugs, of course, itraconazole, suba-itraconazole, they have been studied in Australia. They have studied for the Americans for the deep mycosis or systemic mycosis like coccidiosis, histoplasmosis, and not studied for the dermatophytosis. So we got to study about this, and unless until we have some study, it's very difficult to believe. But people are prescribing and they're getting a result. So now we'll go by the ground reality. So we'll wait for the more data, but we'll go for the next question, Sheetal.
Yes, sir.
People are confused about the 50 milligram, 65 milligram, and various doses. So can you elaborate on that?
Yes, sir. I think the first suba-itraconazole which came was actually 50 milligram. And like I mentioned in one of the studies where I marked out the bioequivalence. Now, when a bioequivalence study is performed, I believe it should be at least between 80 to 125%. So from what I understand from certain discussions with the researchers who have done the studies on suba-itraconazole, 50 milligram does reach up to 80 to 90% of bioequivalence. Now, if we use 65 milligram, it will reach slightly higher. So that was the idea of using 65 milligram. And also because suba-itraconazole is approved mainly by US FDA, and US FDA standards are more stringent as compared to European or definitely Indian standards. So 65 milligram, that is how from 50, they suddenly jumped up to 65 milligram. And because it has been used for systemic fungal infection, that these are the three reasons why it was a jump over from 50 to 65 milligram. But I feel practically speaking for dermatophytosis, 50 milligram is sufficient equivalent of 100 milligrams. Because I have done a brief clinical study on this, means I'm not published it, but it was equivalent of 100 milligram, means I didn't have to give for a longer period than what I prescribe conventional itraconazole.
Thank you for that, because this was the question is asked by almost each and everybody.
Add on that?
Yes, yes.
So sorry to interrupt
yes,
you.
Sushil. No, Sushil, go ahead.
Sir, actually, when the study was done, 50 milligram of suba-itraconazole versus 100 milligram of conventional itraconazole, when we give 50 milligram of suba-itraconazole, the amount of the itraconazole that is absorbed is 46.77 milligram. And when you give 100 milligram of conventional itraconazole, the originator brand, it was 55.
55, yeah, correct.
So 55 being more than the 46. That's why they actually increase from 50 to 65, so that the amount of the itraconazole with 65 milligram of suba-itraconazole becomes 56. So just 1 milligram more than the conventional itraconazole. But they are only comparable to the doses. They are not interconvertible. And actually how much that there is a difference in the clinical efficacy with this, as you rightly mentioned, remains to be known. So we have still a long way to tell that whether the doses are equivalent in terms of absorption, but whether the efficacy rates are also important. And the as it is not approved by FDA or DCGI, we have no data of skin kinetics, because basically they are approved for invasive fungal infection. So that is one of the biggest limitation of suba-itraconazole as of now. But if the data comes in the future, definitely it needs to be tested in the clinical setup.
What you said is correct. We need the skin concentration or concentration in stratum corneum more than only serum. Because what you are doing, that serum, the concentration is increasing, but that not necessarily it will increase the concentration stratum corneum. We need study, we need some evidences, and I hope pharmaceutical will take interest. That's why I keep on telling all our IIDL colleagues and is IIDL that always ask them to get involved in the research pharmaceuticals than just giving the sponsorship, because what we require is a research, and that will have higher value than just getting the sponsorship for our conferences. That is one of my message. I remember about the itraconazole, not the conventional. There's a story of 2000. that one of the pharmaceutical, they approached me because I'm talking of cryptococcal meningitis. We used to see many patients of HIV. They said, sir, start using itraconazole for cryptococcal meningitis. We'll take you Switzerland, family will take you Switzerland. I said, it's a good idea. You can take me or my family to Switzerland, but itraconazole is not good drug. I'm talking conventional itraconazole for cryptococcal meningitis. Only for maintenance we can use it, but not as a initial treatment or what is called consolidation treatment. The drug of choice is, of course, amphotericin B and IV fluconazole. So, but about suba-itraconazole, their studies are done and it's been approved by the FDA USA. So now we'll take questions from the audience. The first question is, which antifungal given together orally are synergetic and make recovery faster by initially shorten the duration of recovery by, a question is asked by Harshad Hora. I think I'll ask Sheetal.
Sir, if he is talking about combination oral antifungals, I think we already said they are not to be used. Yes, but oral and topical definitely, preferably of two different groups. But there are people who are using oral azole as well as a topical azole, and they are getting good results.
Thank you. Now the next question is, maximum for how many days we can prescribe itraconazole for recurrent fungal infection? Milin, Dr. Deshmukh. Question is asked by Habibullah.
Yeah, 8 to 10 weeks.
Yeah.
We can prescribe itraconazole for 8 to 10.
If you want to continue longer period, because in HIV maintenance we are given about 6 months, 8 months, and 9 months, we have to only monitor CBC, LFT, and as Sheetal has mentioned, when you are prescribing itraconazole, you have to be very careful about the cardiac condition. Cardiac condition, you have to very cardiac history is very important. Yeah. Yes, Milind, go ahead. Yeah.
Yes, sir. As you correctly said, in all immunocompromised states, we can certainly give up to 6 months, but in conventional recalcitrant dermatophytosis, 6 to 8 weeks, as far as my knowledge goes, is quite sufficient.
Yeah, most of the cases sufficient. I'll go to now. Anupama, which topical antifungal you prefer in the recalcitrant dermatophytic infection? Topical.
Ibuprofen or even fluconazole works well, sir.
But any other panelists you can contribute, because this is a very good question.
Moisturizing agent. Yeah.
No, antifungal topical. Yeah.
Even sertaconazole sometimes works better.
Yeah, because now we have got almost hundreds of drugs, no? Yeah, Sheetal?
Sir, in recalcitrant ones, I prefer amorolfine or cyclopyroxolamine. I also use 5% salicylic acid in acetone also.
Dr. Nitin Chaudhary?
My choice is for resistant ibuprofen.
Okay, ibuprofen, sertaconazole, laliconazole, these are the higher amorphine. But you know, as Sheetal says, I have started using salicylic acid along with others. You know, many patients who are not responding use salicylic acid. It works very well, but only thing is a large area, then you have to be a little bit careful, because if you apply for longer period, salicylism you have to think of, and irritation. But salicylic is one of the good one, at least I found in my practice. I think Sheetal has mentioned. What about the other panelists?
Salicylic pill can be done.
Yes, correct. That sounds because I got a cosmetic clinic. So the doctors from cosmetic clinic, they said, sir, why don't you send it to us? We'll do salicylic pill. Yeah.
So we have also used salicylic acid pills with good effect. The only argument that is theoretically hold is when we remove too much of stratum corneum, and if you are giving concomitant drugs like itraconazole, the itraconazole, which has achieved a good concentration in the stratum corneum, has a tendency to get washed away. So I think we can do salicylic acid pill, but later on followed by itraconazole therapy rather than giving it simultaneously.
When you should be given short period, yes, 1 or 2 weeks, and then you can switch over to that short. Of course, we should not give for the longer. I think Sauji and his colleagues, no, they have got a paper on salicylic, no, from Nagpur. Yeah. So we'll go for the next question. What are the parameters you consider to choose a molecule when the patient comes with a recurrent fungal infection? I think this is the question I'm asking Dr. Chaudhary. What are the parameters you look, means what are the factors you looked in patient when you are prescribing the drugs?
The drug he should not have been used first initial period, because that means he is not responding to that. So you should change the group of the drug, of that drug, and whatever is your line of treatment, you should maintain it. You should not get drifted by what he is telling, that he has initially used itraconazole and it is not, even if it is not responding, you should again start with itraconazole and your choice of your topical antifungal.
Dr. Milind Deshmukh.
So I agree with Dr. Nitin. The first line of treatment should be itraconazole, even the drug has been used previously. There is no point in changing the drug. And again, going back to the basics, with good amount of skin moisturizer and antifungal topically also, we can go ahead with the formulation.
But as far as factor is concerned, we know that patient has to take for a long term. So first the patient should afford these drugs or not. I'll remember I was taking a lecture at Varanasi. There are about 250 doctors. One of the doctors who is from the homeopathic, Unani doctor, he said, sir, I'm a fungal specialist. I said, what is the meaning of that? He said, my clinic, I put up the board, specialist in ringworm, specialist in this fungal infection. Said, what you're talking? He said, any patient comes to my clinic, I give treatment for 8 to 10 weeks. And first things I ask about him, find out whether he can afford or not. Because if you write for a longer time and patient is not able to take it, I think it's not going to work. So I remember, so first see the cost of the drug is very important. Secondly, drug-drug interaction has to be taken in because patients are already having the comorbidity. Because I remember terbinafine is a very safe drug, but the patient is taking antipsychotic drugs. Terbinafine has got drug-drug interaction with the antipsychotic drug. That is the only thing. Otherwise, other thing about the patient, they feel, many doctors, they feel itraconazole has got lot of drug-drug interaction. Fluconazole also must be having, but fluconazole metabolism is through 2D9, not through what is called 3A4, 450 cytochrome, that is substrate 3A4, and that's why the fluconazole can be also used with rifampicin, can be used with other drugs like inhibitors and inducer, like rifampicin or atorvastatin can be used, but itraconazole cannot be used. So many factors should be taken in account before prescribing the drugs, and it should be available also. We'll go for the next question. Which drug is preferred in itraconazole resistant cases? Sheetal?
There is no proven itraconazole resistance actually. So that term itself is a little, I will be a little skeptical. I would look at more of the other issues, like whether there is familial tinea, whether the patient is compliant, whether the patient is using a good brand or not. I would actually break open the capsule and see if there are, at least if the conventional itraconazole they are using, then at least I would take a look at the pellets, whatever brand they are using. And I would not really term it as itraconazole resistant. I would look at the other factors which are there. So.
Sushil?
Sir, in these cases, suba-itraconazole can be tried.
Yeah,
Since
okay.
the bioavailability is.
Yes, correct. Very good. Yeah. Sushil?
I agree with Sheetal ma'am. If I come across a patient of itraconazole related clinical failure, I will try to assess what are the factors responsible for it, and maybe switching over to the good quality brand and counseling of the patient and asking him to adhere to the therapy may work for the patient.
Yeah, I entirely agree. Whenever the patient fails to improve, we have to find out the first is the compliance, adherence, that is very important. Secondly, patient is taking regularly or not. And in spite of that, because many doctor, many patient comes to my clinic, as you people say, they say that we are prescribing drugs. I tell them you take same drugs, but we counsel to the patient at least 20 minutes how the adherence and compliance. So first you find out either resistance or clinical failure, as Sushil has said, and as Anupama said, if it is adherence is good, but the adherence and the compliance you have to spend a lot of time. Just don't go by patient I'm taking regularly. That is not called adherence. Most of the time they will give wrong history. You have to spend more time. And if it fails, you can use suba. This is the role of suba-itraconazole. That is the perfect role of suba-itraconazole. But I'll tell you, there is a study from this Dr. Sabir Sardana. He has done a lot of studies that itraconazole terbinafine fails, fluconazole works, and I can tell you, I have not come across any single patient who has failed on fluconazole in last 4 years, because I'm using it almost all daily. So we'll go for the next. This question was from Dr. Sagar Makhija. Next question is, what is the percent of salicylic? This question is from Dr. Sri Krishna. What should be the percentage of salicylic? Sheetal?
Sir, I generally use 5% salicylic acid prepared in acetone.
Okay, then I'll ask Sushil. What should be the percentage?
So we have actually using 10 to 20% of salicylic acid because I don't really think 5% salicylic acid will have keratolytic effect as would have been desired for dermatophytosis.
Yeah, see, I was conducting one this I think Cuticon Hyderabad about 2 months back, and this question was discussed. Many said it is 1.5%, 2%, but many of them they said, sir, it is more than 3%. Then it acts as a keratolytic. Less than that doesn't act as a keratolytic, because now many lotions have come, no, 1.5%, 2%. So the percentage has to be more than 3%. So 10%, 20 salicylic acid pill is I think 20%. Okay. So next question, doc, which drugs we are? How long we should use terbinafine in lactation? Anybody, Anupama?
Clinical cure, sir. Till the patient.
I'll ask terbinafine. How long we should use terbinafine in?
4 weeks to 6 weeks.
Yeah, we can use longer period, but the drug of choice during lactation and the safe drug and effective drug is fluconazole. So fluconazole can be used. Terbinafine also can be used, but fluconazole is safer drug. We'll go for the next question. Can we give 2 topical antifungal of different category or the same category? I think Sheetal has answered, but other panelists. Pardon? Yeah, there are what we call the synergistic effect. Even the same group will have synergistic. Even the other group also got synergistic. But it's my personal guts feeling. Now we are saying the concentration MIC required is going up. So I feel better to use for the same group. So you are giving systemic and local. So the concentration will be higher. That is my feeling. But you can use both, and both are effective. That is the consensus across the country.
I agree with you, sir.
Yes. So now we'll close it because it's almost 9:15. I would look to have message from Sheetal. What is your message about the suba-itraconazole? Yeah.
Itraconazole versus conventional itraconazole, because of the bioavailability and improved compliance, I think can be preferred. But overall, I don't see it totally replacing conventional itraconazole, but definitely more compliance because of the improved bioavailability and not the necessity of using it with food. So the patient can have it whenever he's in the office, also not necessary to have a heavy meal. So definitely it has an advantage over conventional itraconazole also.
So you feel we should not use in each and every patient, but those cases we are not responding, I think this will drug. Thank you, Sheetal. I'll ask Milind Deshmukh. Your message.
Sir, I agree with Sheetal. The cost factor additionally has a effect on the chronicity of the disease and the treatment protocol. That again should be kept in mind. And yes, Suba-itraconazole is the first line of treatment, at least in my clinic.
Anupama, what is your message? Yeah.
Usually when the patient comes to us, they have already taken all the therapies. So in such patients, Suba-itraconazole, as Dr. Sheetal said, 65 milligrams, that would be can be used because patients already have taken conventional itraconazole before coming to us. So in those patients, we can do the trials of Suba-itraconazole and see their response.
Now, Sushil.
Yes, sir, it can be tried, but it cannot be recommended in each and every patient. I think we will try it and develop our own experience. And with regards to its comparison with conventional itraconazole, and that is what, as our experience will evolve over a period of time, that's why that is the time I think we can safely or confidently recommend Suba-itraconazole to our patients.
Thank you, Dr. Chaudhary.
Conventional itraconazole is better absorbed immediately after food, and that too with acidic food or fatty food. Nowadays, many people are on diet, not taking regular food, and their food habits are different. Many IT people are taking not diet in a fixed schedule fashion. So in those people, the Suba-itraconazole will be better option because they will have good bioavailability and it will be more helpful.
Thank you, Dr. Chaudhary. Thank you, Sheetal and all panelists. And I entirely agree. We need many more drugs because you are finding very difficult. Whatever the drugs are available are not enough. And we must thank all pharmaceuticals that are coming with the new drugs. But as Sushil says, the new drugs are there, but the new drugs, pharmaceutical must come forward and they should get studied in our country. That will be more useful and that will give more confidence and everybody will be benefited. We will be benefited, patients will be benefited and pharmaceutical. So my request to Manor, please get involved, get some study done from anywhere but in our country. And I think I'll thank you everybody and I'll hand over to Subhojit.
And that they should be cost effective, sir.
Yes, this is a very important point that it has to be cost effective. So the message is given to pharmaceuticals.
We believe in coming up with newer products, which is backed by scientifically. So we will continue that, our endeavor, and also we will also keep on seeing, as Dr. Saple sir said, that where we can partner in the research in our own country. So it's all about making India right now. So we would like to promote that as an organization also. So before we close, I would like to also extend my thanks to Dr. DG Saple, so that because sir is the has made the brainchilding of this entire program, and Dr. Sheetal Pujari, Dr. Nitin Chaudhary, Dr. Milind Deshmukh, Dr. Anupama Kujjarkar, and Dr. Sushil Pandey, who are present for today's program. I would also extend my thanks to the entire team of Mumbai and Maharashtra of our Manor, which was led by Mr. Swapnil and Mr. Sudesh, and they have extended, and because we had got about 160 people, 160 doctors and 160 people who have logged in for this program, plus another 50 plus people have been watching it on YouTube. So about 200 people have been viewing this program right now. So that's a good number, and I think that's a fabulous job that by the team. Also internally, our AVP marketing, Amesh sir, GM sales, Mr. Shesha Reddy, Patnaik sir, who is our EVP for this for the divisions. I would like to thank them. Also, nothing would end by before we need to thank our management who have allowed us to conduct this program, and also the support provided by the entire marketing team, which is Mr. Shashank and his team has entirely supported us. And I think we have been 2 days engaging with Spirant, and the entire team of Spirant, which is led by Dr. Manish, has helped us to conduct this program very smoothly. And of course, my entire sales team. Thank you all for your support and for this program. Thank you, sir. Thank you, ma'am.